I am joined here on the stage shortly by Dr. Phil Dickison, our speaker for the National Faculty Meeting today. I hope you all had a great night and that you've already enjoyed today's SPUNT lecture and that you're ready to continue learning about innovations in nursing education and the opportunities to network with colleagues. What an exciting summit we've had. From the very beginning keynote through Bev's exhilarating CEO address, aren't I glad that I didn't have to follow her? The dynamic SPUNT lecture by Dr. K.T. Waxman, all of that has been wonderful. Over the past several years, though, the Next Generation NCLEX has become like a household name in our nursing education programs. Yesterday, the deans, directors, and chairs had like the appetizer of the course of knowledge that we're going to begin to explore yet today. And that was a conversation with Dr. Dickison. Now it's your special opportunity to listen to Dr. Dickison, engage in a dialogue with him. Therefore, it is my distinct honor to introduce to you Dr. Philip Dickison. He is the, hang on while I say his whole title, Chief Officer, Operations and Examinations at the National Council of State Boards of Nursing. He was previously Chief Officer of Examinations at NCSBN. In his current role, he oversees programs and services related to the operation of the organization, including marketing and communication, performance measurement and standard setting, member relations, and human resources departments. In his spare time, no, that's not true. He has no spare time. Active in the certification and licensure community for more than 30 years, prior to joining the NCSBN, Dr. Dickison was Director of Health Professions Testing for Elsevier and Associate Director of the National Registry of Emergency Medical Technicians. He also served 11 years in the United States Air Force as a medical service specialist, a medic. He received his BBA from Mount Vernon Nazarene University, Ohio, and his PhD in quantitative research and evaluation and measurement in education from The Ohio State University. The author of numerous papers and articles, he is a member of the Psychometric Society and the Association of Test Publishers. It is my pleasure to invite Dr. Dickison to the podium.
What a great honor to be here and to present to you. I know about a year ago I was here and sort of laid out where we started from, what was going on with the NCLEX, what the research looked like, and I want to come back and give you some updates. So one of the things I promised to do at that time was to make it as transparent as possible and bring you along for the ride, if you will, or for the journey that we started. So I have to tell you, after making that promise of transparency, I learned a few things. Yeah. I still think it's the right thing to do. However, I do want you to know that what I learned was if you don't have all of the answers, people will make them up or fill in the blanks or whatever. And so I apologize for that up front. And I want to tell you what we've done now and perhaps do some mea culpas for that, but also more importantly, fill in those blanks for you. So I know there are some rumors, there are some things I'll either confirm or deny those rumors and give you the facts here today and hopefully open up some conversations to you. Let me tell you one of the first things that I think we made a bit of a mistake on, and that is how we named the model. We named it the clinical judgment model, and that created a lot of confusion in education and other places because what it seemed to turn out to do was be a belief that we were either replacing the nursing process or replacing the valid models you're already using for teaching clinical judgment. So we're officially renaming this the Clinical Judgment Measurement Model. It's about measurement. It's not about teaching clinical judgment. You already have those valid models, and I want to show them to you. We did our early research, I showed you this earlier, around some of Dr. Benner's, Dr. Tanner's, and Dr. Laster's changes or enhancements to those. Those are what I call, I think Kathy's out in the audience, but she calls these phenomenological models, and I call them mental models. She's more correct, by the way, but it's hard to say phenomenological. So, because I told you earlier, when I was in my psychometric training, they used a lot of big words, and I couldn't really get those. It sounded like blah, 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 blah. So I had to put them in words I understood. I understand mental models. So the mental models that you use are valid. They're reliable. They're very good in how we define how our students think through issues. We weren't trying to replace those. What we're trying to do is measure how well those are doing. It's something we haven't been able to do over a number of years because we didn't have the measurement models. So we're trying to figure out a way to measure those, and we have been pretty successful. I'm going to show you where we've ended up at today. So, to put one roomer to bed, are we going to require educators to teach the clinical judgment measurement model? No, but we are going to use it to measure the models that you are using. Does that make sense? So I want to erase that. Now, what does that really mean? It means these things. We've done a lot of research. We know. We, in fact, do know that you are, by our research, that you are already teaching clinical judgment. Now, in full honesty, there's a variability of how well we're doing that, right? You have some really great programs. You've got some marginal programs. And I am going to tell you that the measurement model should not affect those that are doing very well in clinical judgment teaching. However, if you're not doing that or you haven't added it to your curriculum, you may need to do something. But it's not teaching our measurement model. It's adopting one of the previous models I just showed you. Let me go back to that. One of those. Adopt it, teach it, we're going to measure it. So the other thing is, there was this belief that somehow we were going to replace the nursing process. Hear me clearly, that is not true. That is not going to happen. The nursing process has been around and been a very valuable tool for nursing throughout its history. The point wasn't to replace it, the point was to measure it. I will tell you some of the things we have found out, though, with our measurement model, and I would warn you to think about this. I know if I talk to educators, they say they teach the measurement model, the nursing process, in a way that is iterative, that you gather information and you keep going and you circle back, get more information. What we found out in our measurement model is that there are a fair number of new graduates who treat the nursing process as a linear, secular process. Do you know what that means? What it means is they start on one end, they follow one hypothesis, they follow it all the way through regardless, till they get to the end and evaluate, and if that isn't correct, what do? They go back. Well, we're suggesting, and what you know as educators, that's not really how we operate. We iterate through that entire process, and the measurement model will be able to measure how well they're doing that. So this is one of the first times I've shown this slide. What I wanted to show you is that the outside of everything that we do is the nursing process. Inside are those elements that relate to it, and you can see the arrows going back and forth. What it suggests is that there's this iterative process that goes on underneath the nursing process called clinical decision making. And that is what we're attempting to measure. So, I can tell you this. Yes, both RN and PN exams are going to be measured in this way. I can also tell you that the current research shows that while PNs do have elements of clinical judgment, that they are not the same as RNs. For instance, the focus on hypothesis generation for PNs is less than it is for RNs, because in the practice analysis and what we're seeing them do, this is a lower, they do this less often than they do other things, but they actually do it, and so the items would develop that would measure that would be around the scope of the things they do that require hypothesis generation. All right, here's an apology to every educator out there for the last 25 years, and I was one carrying this message, and there was a reason it was carried. Remember, how many of you used case studies before? How many used them when you were in school, had case studies? And what did we tell you about those? Don't use them. You know why we told you not to use them? Because we couldn't measure them well. Because we couldn't deal with the idea that there might be, if in fact you went forward and found more information, you might go back and change an answer. We didn't know how to deal with that. We now absolutely know how to deal with that, and I'm going to show you in a minute how we're going to do that. But here's the point. My apologies, use case studies. They're different item types you can put in it, but it's still a case study. It needs to go through the whole case because we get more information. So what you're going to see in the NGN is this. It will use case studies. It will follow sort of a fidelity approach like any other case study, and it will follow the 6 boxes of the process. So when one of your students on the NGN gets a case study, they can be sure that it's going to have 6 questions with it. And those 6 questions will follow the model. Now here's the important point. I said follow the model. If the model's iterative, does that mean all 6 questions will start from the beginning and go to the end? That's not necessarily true, because in the iterative it may push you back to one of the earlier boxes because it gave you more information. You need to rethink your decision, which is how we operate. So, but you can be assured that they will be that. Now I'll give you a sneak peek on what we know about exam design. And this is, I'm being transparent again, and I hope next year I don't have to come back and apologize. But I want you to know where we're at in our study. We believe, given our research, that the exam will look this way. How many of you have heard that every question on the NCLEX NGN will be these new items? Good. That's not going to be true. Remember, you still have to have all of the other things we need to measure, right? So there's going to be the same NCLEX questions that you're seeing today and some of these. How many of these? We expect on a minimum length exam. Minimum length exam being 60 items. Those are the people who are doing really well or really poor, are going to get anywhere from 2 sets to 5, because that would give us enough information to make judgments or to make a measurement decision around clinical judgment. You can imagine that it is possible someone going a full-length exam might get more than that, might get less than that. So we think it's somewhere between 2 and 5. If I have to come back and apologize next year, I will, and say it's 7. I'm sorry for that now. All right? I'm telling you, I apologize up front. But we think that. I want you to know where we're at on that. The other thing is it possible to take just one of the new item types and measure a current NCLEX concept? The answer is yes. So there may be, much like our alternate item types now, there may be some of these that are standalone. So that's what we think that exam is going to look like in the future. So what I want to show you is what a case study might look like. By the way, remember that everything that we're doing here is going to go through the same development process, meaning our diff analysis, our sensitivity analysis is going to do all of those things. None of that changes. These items have started to go through that process, but I wanted to show you in a sample what it might look like. So what you're going to start seeing is On the left side of the screen, something that looks like this, where the case study isn't some 3-line sort of only relevant information. It's what a nurse might see in a patient record or a client record. And notice that tab. I want you to keep an eye on that nursing note tab, because you can imagine, like a file folder, I can increase those tabs. So you might see one that says lab results. You might see one that says, I don't know, a lot of things, and we'll show you them as they come up. But so this is what they would see on the left, or the left side of the screen. On the right would be the question. Let me show you what it looks like. There you go. This would be a drag and drop. This is not new. You do drag and drops now. By the way, it's really not new to measurement maybe, but not to actual education, because you've used similar things. Let's see. Oh, yep, on Sesame Street. Right? We just know how to measure it now. So they're just going to drag these in, but notice that the way we used to use drag and drops was to put things in an order. This is more about how are you going to find the top findings, or what is most important, or what's the antecedent to this. Those are types of things that can happen here the way we think in the Benner model, in the Tanner model, in the information processing model. They have to recognize cues, though. Remember, there's relevant and irrelevant cues. They need to find the ones that are relevant to the situation. So here's the second item. Notice that the nursing note didn't change. It follows you along. So you don't have to go back. All the information follows you through this whole thing. And then you have this is called a matrix item. Here's an interesting thing about a matrix item. I think I've said this before, but when we have these multiple, what do we call them? Multiple choice, extended multiple choice, right? So you get like 6 things you can choose. We don't tell you how many you need to choose, how many must you choose. We don't tell you that. This is an expansion of that. Except for having only 6, you might have 18 of these. And notice they're in columns. So scoring is going to be a problem, but I'll talk to you about how we're going to do that. This would be to analyze those cues. So you determine if, in fact, things like, is it indicated? Is it not indicated? Is it potential harm, unpotential harm? You can have all these columns and actually have them analyze those cues for the next step. Then you go on to this one. Notice the nursing note hasn't changed again. We're still using the same nursing note. We might have added something to it. It's always good to read. We don't tell you. You might be intuitive and know. However, you might want to read it. That'd be my advice to your students, by the way. You might want to read it. And if they put a tab up there, it's probably something you want to click on. That'd be my other advice to your students. This is called a close item. Here's another thing. How many of you have seen a highlight magazine in your youth? Yeah. So this isn't new either, by the way. This is the Goofus and Gallant article. Right? So you just go through. If you pick Goofus, your next thing to fill in had to be something that Goofus would have done. And you didn't mix up Goofus and Gallant's responses. This is the same thing that happens here. We just found ways to measure it. So you can see there's a drop down on each one of those, and they have to then, in fact, pick the story they choose, much like Goofus and Gallant. And this is about prioritizing hypotheses. Uh-oh, something happened. Now we've added something to the nursing note. You'll notice that, by the way, we didn't cue them, we added something. Why wouldn't we cue them that we added something? Because that's not how life works. That's not how we practice. They need to know. They need to be observant. So there it is. We added something. You got a different looking item, but here they have to decide if it's indicated, not indicated, or contraindicated. Aren't those decisions we want them to make? And these are the findings. Now what do you do with those? So here's your generating solutions. Here's what we call a highlight item. Notice nothing added here. But this is really nothing more than a hotspot item. It looks really cool because you highlight something, but it's no different than our old hotspot items. We just enhance it. And this looks a lot like one of those extended multiple choices. It's not that much different. It's sort of a presentation, but it helps us get to a measurement a little bit better. New tab. Orders. So we have a tab for orders now. Again, we don't tell them that because they should see it. They should be looking for it. They should be following this case through expecting it. And so they have to look at the nursing note, they have to look at the orders, and then they have to determine if, in fact, if it's important, if it's no change, should they decline it? There's a lot of things you can do with this item. My point is you don't have to use those same columns. It's no different in your classroom when you go through a discourse with your students in some lab or anywhere else where you start asking them to tell you, is this important, isn't it important? We found a way to put it on paper where it is a bit constrained, I get, but that's what measurement has to do, and we're able to then put this into a measurement model. And so here's what it would look like, left and right screen. So it always follows them. They can go back and forth between these tabs. These are what the item types would look like. Be careful. I'm not telling you to write those items. I am telling you that that's the item types that we're going to get to. If you want to do an assessment in your classroom, you don't have to put it on paper. You can follow the model through class discourse. By the way, assessment doesn't necessarily mean exam. There are lots of ways to do this, and we should think about that. So a case study summary, it's a real-world situation, case study that we follow through the model, and point is there might be multiple tabs. You saw 2. We have some items that 4 and 5 tabs because there'll be lab results. There'll be a variety of things that just show up as if they were in a client chart. So ultimately, there is the new name. See it? Measurement is now in it. We are putting forth a measurement model. How do we measure something that they're seeing in the classroom and we'll see in clinical practice? It has to be evidence-based. And so why am I telling you that? Because there has been research going on since 2009. You know that. There is a new thing that we're going to add to this site, and that's called our FAQs. I recently released, I don't know, it was probably 7 or 8 pages of FAQs. I wanted some comments on how those were going to work and if they were understandable and were we getting the clear information out. I'm waiting for comments to come back. I've got a couple of updates at FAQ, but here's the thing I want you to take away. We will post the most current version in the next 30 days. We'll post the most current version on our side of all the FAQs. So if someone's handing you a document of FAQs, look at the date or go to our site and make sure it's current because we're updating research all the time and things may change that we haven't put on there. So for instance, you're not going to find exam design that I just told you about in the FAQ. Why not? Because I'm going to have to come back here next year and apologize to you when it's 7. We'll give you some updates on exam design, but probably not going to put it out there yet. All right, this is what the new nursing model, the new clinical judgment measurement model looks like. This is solidified. You'll notice we did one thing. We did it because of what we heard from you, which was, where's the nursing model? Where is the nursing process? And so what we did was put it at the bottom of this. Why? Because it's the foundation of every bit of the measurement. It is not another level of measurement. I've heard that too. I'm not sure how to overcome all of that, but the point is, I want you to understand today that what that is shows that the nursing process and the color coding shows where the boxes match up. So we're going to work on explaining that a little better, getting some papers out so you understand the model a little bit better. Last thing I'm going to talk to you about is the scoring. Scoring can only occur not in a dichotomous fashion. Remember, now it's right or wrong. What's the problem with that? The problem with that is that means every distractor is equally bad. And everybody out in this room knows that's not true. If one distractor actually kills the client and one doesn't, should you get the same score? No. So we're going to go to partial credit. Partial credit isn't the real good term for it, but it's what we know it as. By the way, partial credit doesn't mean you get partial credit for killing somebody. You don't. We actually in our world call it polytomous scoring. You only get points for doing the right thing, not for doing the wrong thing. And so we're building a partial credit scoring model or a polytomous scoring model that will help with that. I will leave this so you have time for questions, but you can go to our site, get an update on this in real time as we go along. I appreciate your attention and open it up for questions. Whew. Thank you.
Thank you, Phil. And I have to admit, I've never heard so much laughter about the NCLEX exam. That was really a great presentation. So now we're ready to ask you to participate by asking questions. Please ask your question briefly and succinctly and keep it to within 1 minute of a time frame. Start by saying your name and your school, and know that if you aren't within the 1 minute, we might cut off your mic or signal you, as our president said, you know, when you were getting the box lunch. Yes, so that we can get more than one question in. Is there anyone at the microphone?
Over there. I think over there.
Hi, I'm Larry Slater, Director of Undergraduate Programs at NYU Rory Myers College of Nursing. 2 quick questions. Number 1, we've been told in the past to not put extraneous information on our multiple choice questions. Should we now put that back in to more easily mimic? And question number 2, in some of these case-based things that you're looking at, that it says like screen 2 of 4, 2 of 6, will students now be allowed to back navigate to self-correct, or are they only going to be able to go forward as they currently can on the NCLEX?
They will only be able to go forward, but all the information will carry, so they don't need to go back and get information. But their answer, much like real time, is their answer. We get them more so they can correct. All right? They can't change what they did because you can't change what you do. You can improve on that so it moves forward with them. They get the information, they can correct it as they go. I didn't hear your first question correctly. I'm not sure what you asked me.
In the past, we've been told at many meetings to not put too much extraneous information in the stem of a multiple choice or select all that apply question. So my question was, as we're going forward, maybe we should start putting back in more of that information so they have to determine what's relevant.
I couldn't agree more. I think you need to do what I call fidelity, which is put all of the information up in there. They have to decipher what is relevant and irrelevant instead of only giving them relevant information. Now, that doesn't mean that you start an item on a bright sunny day in DC. All right? It's not a book. But it is, these are the things I would see if I walked into a client room. I should therefore have it in my item because that is what my nurse will see as well. Does that help?
It does. I mean, because some of the specific things they say are, don't put an age or a gender or something unless it's relevant to the question. So, I mean, there's
I think
there's
you
a
have
lot
to
of things
be,
like that.
not to get it too long-winded because we're taking up other people's time, I'm sorry, but what you've got to be careful about is we're going to put that in, but you'd have to be careful that you're not creating a bias or a diversity or a sensitivity issue. So don't just randomly put them in. You need to think it through if you're going to put them in so you're not creating those diversity or cultural issues.
Great. We'll go to this microphone here next, please.
Kayla Krobarger from the University of West Georgia. On those new question types that you've been discussing about clinical judgment, will there be an increased amount of time factored in because of the increased amount of information they're reading through? Thank you.
So we're investigating right now. We actually think the exam might shorten, and that might surprise you. Yes, it takes longer to get these questions, but we get more information. And so in a measurement world, it's a time information thing. The more information you do, the less items you need and the less time you need. So we don't know the answer to that. We're going on the assumption, 1, that it's a cat, 2, that it is no longer than 6 hours. Can we actually shorten that? We're investigating that now.
Thank you.
Microphone over here.
Hello, Megan Rogers, University of Texas at Arlington. My question is centered around the National Council's plans for empirical validity of this model. As I understand, there's been some reliability, usability studies, but we know that an invalid model can still be reliably invalid.
That's correct. So we have a 40-page validity framework that was approved externally by the psychometric measurement community, and we're currently going through all of that research. It's very positive at this point in time. So we're doing a lot of work that will become public at some point in time. It's not completed, so it has a 6-tier framework on it that we're doing the research now.
Thank you.
Yeah.
And I think there's another question back here at the center microphone.
Hi, Selena Bliss, Yavapai College in Prescott, Arizona. First of all, I want to say referencing Goofus and Gallant was really dating you, and it caught my attention. I can relate. I think we're the same age. Question is on the parts that are collaborative for nursing interventions. It said that on one of the examples, the nurse would perform, and one of the options was CT. I just want to verify that those are all legitimate answers, because our students say, oh, well, I need an order to get a CT, so I'm not going to answer it in that order. So I just want to confirm those options are legitimate.
They would be legitimate, but if you're only picking 4, you have to pick the ones that are appropriate. Is that the item you were looking at?
Yeah, I was more or less sifting out what needs a physician or healthcare provider order.
So remember that those items would go through an approval process. In fact, that item might have that removed if our process says that's not relevant or not a plausible. Or it has to be plausible to be in it.
Right, that's the word. And the STEM might more likely say which of the following would the nurse verify has been ordered or something.
Correct, yes, something like that. Correct.
We have time for one more question. I think there was somebody waiting at this microphone here.
Over
Yes?
here to your
Over
right.
there. Okay,
To your
great.
right,
Thank
yeah.
you.
I'm Linda Kennedy from Hood College in Maryland. My question to you is, do you expect that the national passing rate will fall like it has with other changes? And is the basic way that you're going to calculate whether somebody passes or not still the Logit model?
So the answer is yes, we will keep the same scaling so that we can compare over the ages what is happening with the nursing population. That's number one. Number two is with any exam change, we know that there's always a short dip, and about between 2 and 3 months it comes back up. Do I expect that? Why wouldn't I expect that? What you need to know, though, is we've given this exam to 304,000 of your students. And by the way, they weren't taught the measurement model. They were just taught whatever you're teaching them now. Here's what we know. Those people who do very well on the exam, the minimum length passers are doing very well on these items. Its correlation's very high. The people who are doing very poorly on the NCLEX, guess what? They're doing very poor on these items. The correlation is high. Where is the most variability? Right at the cut score. Those people who are struggling at the cut score are struggling with these items. So there's a great deal of reliability. Now, the question came up yesterday, and I will say this. The council still has to do a standard setting. Now, I don't know what that means because that's a board of directors decision. I just provide them evidence. They have to make that decision. So the impact of a new exam right now would be only those students who are very near the cut will be probably impacted by this. Now, how many is that? It could be a lot, because if your education program is only, the variability of education programs, some are really high, some are struggling. Those that are struggling are probably still going to struggle, and this will not help them unless they make some changes. I hope that, I don't know where she went, but I hope that helped.
Great. Thank you for your questions, and let's thank Dr. Dickison again for his great presentation. Thank you.